All right, I think we're going to go ahead and get started. Welcome to day 2 of Uromigos Live and Unplugged. How about a round of applause for day 1? Thanks to all the bladder faculty. I see Shilpa and others here. Really amazing session. Amazing Uromigos Cup semifinal round. There was a lot of discussion about the scoring of that. I got a lot of comments. If you expect it to be like fair or rational, you're going to be disappointed again later today. So it's creative. It's like everything Tom does. It's creative scoring. So we're going to start out with, first of all, thanks again to our sponsors. Obviously, we couldn't do this without you. We really appreciate your support. And broadly, thanks to all the faculty yesterday and today. We appreciate you taking your time and fighting the weather to be here. It means a lot to us. All right, so here's today. We're going to start with prostate cancer. We're going to do half hour, 35, 40 minutes of T-cell directed therapy. There's some new data about immunotherapy broadly, but T-cell engagers specifically. And then we'll spend the balance of time in prostate cancer on radioligands. Take a short break, and then we'll have what we called this, I think, the Rising Star session last year. We switched the name. It's the clinical trial concept session. So we have 5 junior faculty here who each brought sort of a concept, a one-slide schema slide. And we'll spend 10 or 15 minutes sort of discussing and debating and talking about practical things and all sorts of issues around getting trials up and running and executing them. And then in the afternoon, we'll do kidney cancer. The live stream is the IRE challenge. So obviously with TiNivo-2 and other data being presented, we'll talk and discuss and debate. We have a session on frontline therapy and papillary renal cancer following on the Sunny Forecast data presented at ESMO. And then something new we're trying this year is we talk a lot about oligometastatic disease in kidney cancer and prostate, right? And so we thought we'd just sort of take a stab at defining that and what does it mean and sort of discuss and debate, and we'll see where we get in that 30 minutes. And then the final will be the Uromigos Cup final round. Team Japan, fresh off their victory yesterday versus Team USA. It was Team LA last year. We've broadened it. We wrote Dave McDermott in, so it's Team USA. All right, let's keep going with prostate cancer. This is a podcast as well. So if we're referring to slides, Nick, try to describe it on the slide if you can. But welcome to Uromigos Live 2024, T-cell directed therapy in prostate cancer. I have an excellent prostate cancer who happens to be sitting in the exact order that their pictures are. That's a small miracle. So I will turn it over and have you introduce yourselves in sequence. Michael, why don't you start?
Sure. I'm Michael Morris. I'm the prostate cancer section head at MSK.
Hi, I'm Tanya Dorff. I'm the Division Chief for Genitourinary Cancers at City of Hope near Los Angeles.
And I'm Karen Autio. I'm a GU medical oncologist at Memorial Sloan Kettering.
Appreciate, again, you all joining us. So let's dive into T-cell therapy. So this is a slide that I adapted. Niraj Agarwal, who couldn't be here this year, has been here in the past, gave a talk on this broadly at ESMO, and I borrowed some of his slides and rearranged this sort of as an intro slide to talk about T-cell therapy and T-cell engagers, these TCEs in general. And if you look sort of at the top right, I think to me that's the definition. They bypass some of the normal mechanisms for T-cell engagement and stimulation and in essence bring T-cells to the tumor, right? So you see the CD3 positive T-cell, you see a number of drugs that we'll talk about, some of them, not all of them today. And then on the prostate cancer cell, you see the tumor antigens. We'll talk about sort of bottom left upwards, PSMA, which we're familiar with, and we'll talk about in radioligands, of course, STEAP1, and then DLL3, and the various drugs that target them. And these are obviously just a small subset, but the ones that have some clinical data. So again, it's really bringing T cells to the tumor is how I think of T-cell engagers. And on the left are just the definition of some of those antigens that you're familiar with. All right, before we talk about the drugs themselves and the trials and the data, and by the way, Karen helped me make all these slides. Thank you. Actually, she made all the slides, so thank you for that. When I say helped me, I mean she made them. Cytokine release syndrome is a big issue, right? So we're talking about a potentially toxic therapy. We'll get into it in a population that's generally older and comorbid, perhaps in some of our other solid tumors. And cytokine release syndrome, or CRS, is a big deal. So these are the boxes, sort of this so-called Lee criteria. You see the reference down there. Karen, maybe if you could sort of take us through what is CRS, what are the cytokines mediating it, how did this grading get decided? I think the bold sort of points out that grade 2 is a big deal. Like normally we don't think of it as a big deal, right. But if you're on a vasopressor, that's a big deal.
Yeah, definitely. So CRS is sort of this overwhelming inflammatory response that's characterized by pro-inflammatory cytokines like IL-6 and interferon gamma. I usually describe it as in its more severe form, it can look like sepsis. So patients can get hypotensive and tachycardic. They have fevers and chills. For those who can see the slide, there's certainly a different number of organ systems that can be affected. And the grading system that we typically use is the Lee criteria, although there are other grading systems. And I'll just walk through a little bit about how we grade CRS, because I think it's important when we look at it in the context of the trial results. So grade 1 CRS is fever, maybe some chills. It's mostly just sort of symptom management. When you get into grade 2 CRS, things are more tricky, and patients oftentimes have hemodynamic instability, so they may have low blood pressure that responds to IV fluids, or they may need a low dose of a vasopressor, tachycardia, grade 3 transaminitis, which is common, at least with our PSMA-directed bispecific T-cell engagers, can also qualify somebody for a grade 2 CRS. When you get into grade 3 CRS, if it's for hemodynamic instability, those patients are certainly in the ICU.
And it sounds like, just to go back to grade 2, it
Yeah.
sounds like it's a broad range, right? Because you say it's generally inpatient, so not
Yeah.
exclusively, all the way up to ICU.
Correct.
That's a big-
Correct. So grade 2 runs sort of the gamut, and grade 2 can also be you're just in grade 2 because your liver enzymes are elevated, which is very different, obviously, than you need to be on a low dose vasopressor in the ICU. So that all comprises the spectrum of grade 2 CRS.
And then, I'm sorry, you were
And
talking about
then
grade 3.
grade 4 and 5, fortunately, we don't really see too much of that, but that's certainly patients in the ICU and are dying of cytokine release syndrome. I'm not sure if we'll get into later, so the mitigation strategies for CRS, we probably will,
Yeah.
but I would say just generally speaking, we use tocilizumab, IL-6 agonist to mitigate grade 2 CRS, and oftentimes in grade 1 CRS for patients that have comorbidities where we're concerned about the progression of the cytokine
And
release
you treat
syndrome.
with steroids at all or no?
And steroids as well, yeah. Steroids typically in grade 2, and there is concern that too much steroid could potentially decrease the efficacy of these drugs. So we do use steroid pre-medications, but how often to give them in grade 1, grade 2, I think is ongoing discussions.
Generally, the same approach as IO-mediated toxicity, but maybe earlier use of like tocilizumab or
Correct.
an IL-6 antibody. Is that a fair
That's
statement?
fair.
Tanya, you have a ton of experience as well. Anything to add? I mean, it seems like this is a big deal, right? Is that an accurate statement?
Yeah, I mean, it's been one of the challenges with rolling out bispecific T-cell engagers is the high rate of CRS, especially in the first few doses. It does tend to diminish over time. But in those first few doses, trying to send a patient home knowing that they're going to have fever and chills, and you prepare them the best you can, but it can be a lot for them to try to get through it on their own, and a lot of times they sort of do feel more comfortable in the hospital where a nurse can come and help them through the side effects. And then also just thinking about the community, if you have a general hospital, do they have tocilizumab? If a patient shows up having received the bispecific and having CRS, are they equipped?
2 questions. This is generally given, the drug administration is inpatient, or not necessarily?
Usually at least the first dose, although we're trying to minimize the inpatient requirement.
And then they stay for a day, a week?
A day or two
Okay.
at most these days, yeah.
But you have a low threshold to bring them back in the hospital for the reasons you mentioned.
You have to have a really good, reliable system where they can call in and get help and know that they'll get the TOCI if they need it.
And do most emergency room docs, they know what, Pembro or Nivo is, and if they show up, Karen's shaking her head, like, if they say, oh, I got, AMG, whatever, like...
They're not going to know. They're going to treat them for sepsis. They're going to give them,
Yeah.
fluids and vasopressors, but I don't think they're going to know to give TOCI or
They probably don't
or
have
steroids,
it.
at least at this point. I mean, but that's why it's being done in large academic centers while we sort of figure this out and figure out the best way to transition these patients to outpatient.
Got it.
I just want to echo something that Tanya said because I think it's really important. The CRS it's the first few doses, and we tend to do step-up dosing, right? And so they might still have CRS at their target dose, but this isn't something where somebody's on therapy for 3 months and then all of a sudden they're getting hypotensive at home.
Like this
it's
happens,
very
right?
predictable in terms of when the CRS onset is.
Which is right away, basically.
Which is within the
Within
first
a
12
few
hours.
yeah.
Oh, within hours.
And I think before scaring the entire field away, it's worth remembering that, first of all, even with the early days of checkpoint inhibitors, everyone was scared of how to administer them and how to educate the community in managing side effects. And remember that tarlatamab is FDA approved for the use for small cell lung cancer. And we aren't bursting at the seams within patients with a whole bunch of small cell lung cancer patients, and it requires just a day's worth of observation, not necessarily admission. So there is experience. This class of drug is FDA approved. People are managing. So before we say, oh, this is scary,
Always
horrible,
the voice of reason.
We'll learn how to do this.
Yeah.
Patients are getting these therapies as part of routine cancer care now, and
if it's active, we'll figure out the tox management,
exactly.
right? True for any cancer drug. Yeah, I was going to ask you, but I think I know your answer. Like, how scary is this to you? But I think I know your answer. Like,
well, I would call Karen, but I think that if you think of the number of generations of both therapeutics and diagnostics that many of us who have been in the field for a while have had to learn how to do new things. This is just
and we're giving
doing
CAR
a new
T
thing.
cells and other disease and other scarier things.
Yeah.
Obviously, the substrate here, the prostate cancer patients are a little different than an ALL patient or something, right?
Absolutely,
But
absolutely. But the prostate patients aren't necessarily any sicker than the small cell lung cancer patients, right?
Fair.
So I do think that we can learn how to manage this. We'll acquire the skills to do it. And what seems very intimidating right now will be old hat when these drugs hit. They are active. There's the first immunotherapy that we have that's active therapy. So I wouldn't overemphasize the CRS to scare everyone away because, one of these drugs...
Karen suggested I put it as a second slide. Yeah, sure. Tony?
So which one
The microphone.
can be done most likely outpatient?
Give it to him. Tony, use the mic just because we're recording. Thank you.
Which one can be done outpatient, inpatient, etc.? I mean, this is not just CAR T, but in the future, the CAR NK can account seems to have way less CRS, maybe. Some of them need deconditioning. That's where the problem has cyclophosphamide. Other non-need deconditioning. There's always, concern that, especially with chemotherapy, cyclophosphamide, that some of them. We see some in renal cell that patients really progress very fast. So I think this would be important not to treat them all the same. We have a lot of push dynamics-wise at the hospital to move everything outpatient. Which one do you think at first that can be moved mostly outpatient?
Anybody? Tanya?
Well, we'll look at the data, right, for the different agents, or at least some of them. And the AMG 509, the Xaluritamig, has lower rates and lower severity of CRS. And as Karen mentioned, it's very predictable. And so I think these can move outpatient. I didn't mean to sound like overly serious about it. It's just going to take some education of both the patients and the community partners. But the first dose or two, some observation, and just having a phone number you can call, I think, and then the rest can definitely be outpatient.
Part of it is...
Thanks, Dan.
It's not just a drug issue either. It's understanding the patient characteristics that lend themselves to CRS. And also, if you are going to monitor those patients at home, what are the cardinal signs and symptoms that would bring a patient back so that oh, this is not good. And, the thoracic world is figuring this out. There's a thoracic oncologist named Bobby Daly at MSK, who has a grant from NCI to study tarlatamab as an outpatient with visiting nurses and EMS visiting. And to get the back and forth patient characteristics, the signs and symptoms that would be triggers for bringing a patient back, and drug selection, all of those will answer Tony's question is how do we get most efficiently into the outpatient setting?
How do we do it safely? Okay. One more, and then we got to move on from CRS because we're bringing the
baseline clinical characteristic, gender, whatever, or genomic characteristic.
In prostate, we don't have the gender issue, Tony.
No, I'm thinking all GU. Who will have CRS versus others? Like, are patients with autoimmune disease more likely to have CRS? Do you know anything about that?
I don't think we have good predictive biomarkers, honestly, at this point.
Some people think disease burden might because there's so much engagement happening all at once.
But you,
I think it's drug
But not
specific,
really.
and we could always move on, and I think there's a
think we
slide that
should
talks
move on.
about
I
the
think
CRS rates with different drugs.
I think no is the short answer to predictive factors. All right, Tanya, these are your data about AMG 160 or Acapatamab. Maybe just walk us through the slide in a minute or two, and then we'll talk about it.
Yeah, so this was a very large phase 1 trial of a PSMA targeted bispecific in MCRPC that started at really low doses, and as we got to higher doses, we had to implement the step dosing that Karen mentioned to get a little bit of that CRS out of the way, then increase the dose, get a little bit more. And we went all the way up to 0.9, but that was too high, really. So the expansion was at 0.3 as the target with 2 steps to get there, 2 or 3 steps. It was a very high rate of cytokine release, and it was quite strong in many patients, at least in my experience. But we explored a lot of steroid premedication, giving a bolus of fluid. So we learned a lot from this experience about how to try to prevent it or predict it or be ready for it and mitigate it quickly. And as you can see, it was quite effective. We had a lot of PSA declines. We had objective responses. But there was a problem with durability. And in part, I think anti-drug antibodies were a problem. But there could be other explanations as well. We did look at PSMA PETs a little bit. It wasn't.
A slide on that.
Oh, okay.
Yeah,
All right.
don't give it away. Two questions. I mean, grade 3 and 23%, and then 16 in expansion. So whatever maneuvers that you learned and instituted throughout obviously brought that down, but that's still, I don't know, the grade 3 was, multiple vasopressors in the ICU. That seems, again, I don't want to scare everyone, that seems like a lot.
I think they were grading it with an older scale. Was there an older version?
I think what is the grade 4 transaminitis
Okay.
also could get you there for a grade 3 with the Lee criteria.
Okay.
So I think that
I
was
treated
part
more than
of it.
20 patients, and they all had CRS pretty much. Maybe 1 or 2 didn't, but only 1 ever went to ICU and just needed a little bit of vasopressor. So yeah, I think it was really the LFTs.
And is this efficacious? I mean, you see a little bit of PSA decline, a couple of RECIST responses, or a few, I should suppose, in the RPFS. I mean, it sounds like the toxicity was limiting. But if this was more tolerable, would it go forward based on this level of efficacy?
I think we would want to see better durability because it's a big investment. The patient's coming every week.
Yeah.
The cytokine release is pretty severe. We used a bit of TOSI, which can be expensive. So when you're thinking about, the overall cost of this kind of treatment relative to something like CAR T, it adds up pretty quickly. So I don't think this was enough durability of efficacy to move forward.
Okay. Karen, thoughts?
No, I totally agree, and I think we might have a slide that talks a little bit more about that.
Yeah, the next slide is
durability.
yeah.
But I think this was a very heavily pretreated patient population, and I think, although the durability wasn't there, I do think it's impressive that there was the PSA responses that we saw. We really don't ever see this with immune therapies in prostate cancer, so I think it's sort of at least proof of principle that these kind of drugs can work. That was impressive.
Yeah. Let's talk about durability, and then I want to come back to a general drug development question. So, Tanya, this is your spider plot, and this % change is PSA. So, and then weeks on the bottom. So obviously, it looks like 1 long-term responder, sort of the next group of getting into the 20 to 30 weeks, and then others who obviously progress. So, I mean, what was your sense on durability, and how do we build on it, right? I mean, if durability is an issue, well, then it's never going to go anywhere if it's a brief response for all this toxicity, right?
Right. I think we have a lot to learn about who is that one that's, in remission, many, many weeks later, months later, versus the ones who don't respond. I think the ones that responded and then stopped, to me, it seemed like it was associated with anti-drug antibodies. Not all of them were neutralizing, but it almost felt like as we were treating patients and we were saying, oh, his PSA dropped, and now it's going back up, and then the person with the anti-drug antibody data would come on and say, oh, yeah, they started developing it. So it just felt like, from my perspective, that there was a correlation. But there's a lot of interest in whether pre-existing immune activation in the tumor microenvironment actually is predictive of who has these very robust responses.
As measured by?
Like tumor-infiltrating lymphocytes and that kind of thing.
And I just want to ask all of you broadly, like in terms of developing this drug. Actually, one more question before that. Is there a solution to the anti-drug antibody issue? I mean, I don't know a lot about it, but
it seems to be less of an issue with some of the other agents.
Just structure of the drug, right?
Yeah.
It's just drug specific.
Right.
Yeah.
And giving IV as opposed to sub-Q. I mean, there's more ADAs with sub-Q.
I see.
But this is an important building block.
Yeah.
And it's the first step towards having active immunotherapy in prostate cancer. Yes, that first step had led to an abandonment of that drug. But there's enough signal there to say this strategy should be pursued. Anti-drug antibodies can be wrangled out through molecular design changes. CRS can be managed. And the durability issue, is that really a drug issue, or the lack of the drug because of anti-drug antibodies?
Yeah.
So I think that this is an indication that there is a role for immunotherapy in prostate cancer. You just need to now build on that as a strategy to wring out the issues that led to this molecule's abandonment.
And probably heterogeneity in the tumor expression of the antigens is an issue as well that we may have to grapple with. We hope that once the immune system's engaged, there'll be antigen spread, and maybe even if every prostate cancer cell doesn't have PSMA, that the T cells can get to the other ones. But there are often, various populations of prostate cancer in the same patient.
Mm-hmm. This is a slide on PSMA PET. I don't know, Tanya, if you want to comment on this. Michael, I see your name on one of these. But
We'll let Tanya.
Tanya, you want to start?
I'm happy to comment on it, but it's...
Not surprisingly, the PSMA PET activity was associated with benefit from a PSMA-targeted treatment. It's not super unexpected, but it is nice to have this kind of a biomarker versus, tissue, which is a spot in time, often archival.
Yeah.
Something that's more dynamic, like antigen expression. It's nice to be able to look at the phenotype of the PET scans.
Do you think moving forward this should be a mandatory selection tool, or is it still kind of experimental?
If I were a patient, I would want to have the PSMA PET scan and have that factor into decision making. I'm sure we'll talk about it in the context of radioligands as well.
Right.
What I think that this slide illustrates is what we do and we don't know about an imaging biomarker for immunotherapy. The publication that's referenced on the slide, and I recognize this is a podcast, so not everyone can necessarily see that, is an analysis from Vision of the relationship between dosimetry and cancer outcomes with radioligand therapy. And so that does make biologic sense, in the sense that the more you see on the PET, the implication is the more radiation you're going to get with the therapy, the higher the activity level. Now, we don't know what those thresholds are for immunotherapy. We don't know is like the activity level around the tumor directly related to the level of PSMA expression on a PSMA scan. But and how low you can go, right? There isn't necessarily the same set of thresholds for immunotherapeutics, which really are operating on a wholly different principle than delivered radiation activity. So it would be really useful if we could prove that. Right now, I consider it a correlative study to see what those relationships are. but I'm not sure I would use the same metrics that we use for radioligand therapy in a PSMA scan for a bispecific antibody. I do think, though, that one should think about one's original registration trials if there is a question about whether these patients express the target at all. I wouldn't necessarily go into registration, and as Tanya just said, we have a heterogeneous disease. And when we're talking about, for example, DLL3-directed therapy, I can tell you from personal experience doing DLL3 scans on patients, it's very heterogeneous. And in that circumstance, I would use an imaging biomarker because I think that, you don't want to have a bunt or a strikeout in your first, race to registration.
Yeah. Karen, do you have an opinion about integrating PSMA PET into these bispecifics?
I mean, I think in the phase 1 experience, I think it's just extremely important. I think we're learning a lot from it, and while it's different from the question of is it really predictive and should it be part of registration to be determined, but I think it's really important that when we do these large phase 1 studies that we build in as much correlatives as we can, and imaging biomarkers, certainly for PSMA PET, is widely available.
So integration, but not restriction based on
At
PSMA
this point,
PET.
yeah. I mean,
It's certainly, there's no excuse for non-integration for PSMA where you have an imaging agent. I could certainly see the intimidating regulatory and financial issues of developing a new radio tracer specifically for a bispecific antibody program, but there's no excuse not to have every patient on a PSMA-directed therapy getting a PSMA PET to understand both the prognostic and predictive and then treatment outcomes assessment of serial scans with PSMA PET.
Especially in the era of lutetium PSMA, many of the patients enrolling on these PSMA-directed immunotherapy trials will have had radioligand therapy, and the question is targeting that still, effective? So.
Right. Yep.
right. And while I know not everyone can see the slide, there is a slide that just shows that there were patients who had previously had lutetium PSMA 617 who went on the AMG 160 trial, and there was variability in response, but there were patients who still benefited. So it's just to say that just because that target has been targeted before, if you're trying it with a different approach.
Presumably they were PSMA PET positive at baseline here?
It wasn't
It
eligibility.
wasn't required.
It wasn't,
yeah.
so we don't know. Okay.
And that raises the issue not only of serial therapy for one to salvage the other, but integrating the two.
Right.
Love it. All right. This is Kevin Kelly's data published in Cancer Discovery this year, and then some of these data are updated. There was an ESMO poster this year. I think I updated the overall CRS, but he didn't have grade 1, 2, and 3 in the poster, and updated some of the efficacy numbers. So this is a STEAP1 bispecific, STEAP1 CD3 bispecific. You can see what STEAP1 stands for, a high expression in CRPC, not surprisingly. And as you would expect, Tanya, it's kind of like your trial. Big trial, all comers, refractory, visceral, all the kind of patients you get in these late line trials. So Karen, maybe we'll start with you. Sort of first thoughts about this. This one is moving forward, I'm told. Is it that much different than?
I think it is. I mean, the CRS profile is certainly much more favorable than the AMG 160. About 3/4 of patients having some CRS, but mostly all grade 1 and grade 2, which is a lot more manageable. The early efficacy data looks promising with PSA 50% response rates, around 50%. But importantly, the RPFS data that was presented at ESMO is
Pretty decent in this
looks
setting.
great. I mean, it's like 7.8 months.
Yeah.
So, and an overall response rate that was probably double what we saw on AMG 160. So I do think.
So we're moving towards outpatient. There's now a cohort with just observation for 16 hours after the first dose. It's a long observation. But then by the second dose, 4 to 6 hours kind of a thing. So we'll see if we can get it down to that. The toxicity, besides the CRS, is also just different, and maybe there's a slide on it.
There is.
Should have seen the slides ahead of time. But there was a lot more of the neurologic toxicities, including like vision and hearing with the PSMA targeted, and we just don't see any of that with this, which is very nice.
I think it's worth bringing up, since we're talking about the differences in the tox profiles, the differences in the target as well, right? So for those who may not know and who is in your listening audience, STEAP is copiously expressed in prostate cancer. It's a target that we validated, Dan Danila, myself, and Jorge Carrasquillo, quite a number of years ago by imaging patients with a STEAP1 tracer. It is, this was before PSMA PET was available, and it is well expressed in prostate cancer. There is not very much at all in the way of normal organ uptake. So what Tanya is referring to, these neuromusculoskeletal events that relate to the use of this drug, it's not clear that this is an on-target versus an off-target tox. It's really not quite certain what's the cause of it. It is amenable to treatment with steroids and toci. But I think the question is, as Karen was alluding to, is how early do you want to do those maneuvers versus how do you best manage it with something that may not have the risk of impacting efficacy?
So this is from Kevin's poster. I just cut and pasted this musculoskeletal inflammatory AEs, which were not seen with your drug, right? I mean,
they were not
totally
seen
different.
with the 160.
Yeah.
And these are so variable. They can be jaw, they can be a myositis in a muscle, they can be bone pain. Sometimes it's in an area that's known to have a metastasis, sometimes it's not. I don't know what your experience has been, but for me, it's like always a surprise. And in the same patient, it can be different with different doses.
I don't remember my CTCA definitions of musculoinflammatory AEs, but this seems like a lot of grade 3s, right? Those gold bars or whatever at the top. It seems like a fair amount.
Correct.
Yeah, I don't wanna scare anybody,
these are certainly, doesn't necessarily mean that you're being admitted for a grade 3, but they're certainly getting interventions and steroids for a grade 3.
But it's something that's pretty transient, and you prepare the patient for it. I don't think this maybe looks worse than it is, I would say, although I guess there's a spectrum, right? But for one of my patients, he has some dexamethasone, and if the shoulder hurts or the jaw flares up, he takes the dexamethasone and it works.
Have people done muscle biopsies? Is it just like T-cell infiltration? Is it?
I know we just did a muscle biopsy on a patient who's actually having a really difficult time with myositis. That's not back yet.
So we're in progress.
Okay.
We're trying to understand it as a group.
But the treatment algorithm's similar to the other CRS talks we talked about-ish.
I'm curious about the role of tocilizumab.
Yeah,
Do you think it works for this?
I don't really understand biologically why it would work, because it's not.
It's not IL-6 mediated, or we don't really know.
It's not really CRS, right?
Yeah.
It's not CRS.
That's an interesting point, that this is this getting graded and captured in the CRS reporting, or
It's separate because it's not
I think
part of
it's-
the CRS criteria, so it's
I think
getting
it'd have to
captured
be separate,
separately
just
by
looking at the
myositis.
numbers, right?
Yeah,
Because their grade
yeah.
3 was like
Yeah.
2% or something.
It's not getting captured as like an organ system failing, as part of CRS.
Yeah.
So.
Yeah, okay.
And I don't think it should be, because I suspect the management will be different.
But again, what Kevin told me at ESMO is this is moving forward into big randomized trials. I don't know what's public or...
The every 2-week dose, as you can see, those of you who can see the slides, is associated with a lower rate. So in the first month, I think they'll still do weekly to get to target with the step dosing, but the every 2-week will be more patient-friendly and also fewer musculoskeletal toxicity. So yeah, the phase 3 trial should be opening.
And I think it's worth pointing out, new target, new drug, so new adverse event. I think Amgen's doing a great job of trying to understand this. They've developed an international panel of experts to try...
This side effect specifically, yeah.
Specifically the musculoskeletal events, so that there's global expertise being applied to this to really understand how to get under the hood of what the mechanism is to try and flesh this out, because this is an active drug, and nobody wants to have your dosing limited by this when we've really hit on a new class of drug and a new class of target here.
Petros?
Hey guys, great discussion. Very quick question on the topic. Do you think there is opportunity or need to develop specific AE criteria to capture the side effects, or we're okay with a conventional historical CTCAE that were developed in the chemotherapy era. This actually came up in the presidential symposium at ESMO for checkpoint inhibitors, but maybe even more relevant question for this type of entities, and great discussion.
I mean, I think the lead criteria works quite well. I don't think we necessarily need another. I think there's like 5 existing criteria already for CRS. So
like
I would
enough,
say
yeah.
let's do what CAR Ts do and just understand the nuances between grade 2. And I think the myositis will just keep as a separate
Yeah.
CTCAE.
It is hard, though, because they are such diverse events that I think we needed to put them all together and call them musculoskeletal inflammatory, because otherwise, if you report out arthralgias and
They get
muscle
separated.
pain in all these like CTCAE different options, it doesn't give you the picture in quite the same
Yeah.
way.
To answer Petros's question, maybe it's not a new criteria, but there needs to be a new name for this because it's really not just musculoskeletal. There's a vasculitic component, a neurologic component. So
We
if you
come
can
up with a
think
new
of
name right now, I
a
mean,
better
that's-
name for this thing, then that would be good.
But it has to reflect the symptom.
end of the day.
At the end of the day.
What I don't like is that right now it's abbreviated as MSK toxicity,
Yeah,
which I really don't
Actually,
like.
I like that.
We have to move on off of that.
You
Salt
got
is
your
done.
kidney model. So one question, one thing I think we failed to do in the PD-1 inhibitors, and I wish we can go back 10 years, is we start giving steroid. We should, in theory, have given rituximab and spared steroid. Are you thinking of giving toci in things like this and just sparing steroid? Because once you're in steroid, it's such a vicious cycle, ugly.
There certainly are protocols and trials of non-agents that we've talked about today that implement like TOCI
First.
for grade 1 and really trying to hold off on the dexamethasone.
And one question, STEAP1, why not, are you developing ADCs rather than CD3 against STEAP1? Because this is a chemo-sensitive disease.
So there is a company that is developing a full family of therapeutics against STEAP2, not STEAP1,
Okay.
but an RLT, a bispecific, ADCs, et cetera.
Okay.
So, they're closely related. I don't know of any other STEAP1 directed therapy that's been proposed.
But just getting back to the steroid question, those AMG 509 results were in the context of a lot of steroid usage, and yet
Yeah.
it still showed really strong efficacy. Now, maybe we would have seen even more, but these patients all got dexamethasone, PO, IV before each of the first few doses, and then you drop it in cycle 2, although my patient who's been on for 6 or 7 months and is still responding, he's still getting dexamethasone pre-med because it helps reduce the MSK toxicity.
Best part of the session so far. This is just, go ahead, Stephanie.
Could you guys comment on what you see in the blood when this happens? Is it like ESR, CRP, aldolate, like all the things that we see? And do you use like alternative regimens like we do for IOs? Do you use like infliximab or steroid-sparing agents to treat this toxicity? Because I've never heard about this before.
So I will say anecdotally, the CRP, it goes up and then you kind of see a event happen. But again, it reverses very well with steroids. I'm not sure we need to escalate, although it sounds like people are interested in steroid-sparing approaches.
Yeah. And I would say CPK is not necessarily always reflective of this muscular, not MSK,
It's more of
muscular
it's a clinical
toxicity.
diagnosis, unless you do a biopsy, I
Yeah.
guess. No. Just a summary slide. When I looked at the summary slide, it's not as scary as I think. I got less scared looking at this. If you look about, CRS leading to interruption or discontinuation, those are, I guess aside from, 509, it's generally low. And interruption is not necessarily a bad thing, right? We do it with ipi-nivo all the time, et cetera. So that's not necessarily a loss, right?
Right.
So this is obviously more drugs than we've talked about
Yeah.
so far. It didn't seem quite as scary to me.
And I think it's just important, the comment about interruption versus discontinuation is important, but I think if we're getting a lot of interruptions, we have to understand why and figure that out
Yeah.
so that clinicians in the community aren't trying to figure it out after a phase 2.
Have you seen, either of you, or all three of you, seen patients who interrupted/discontinued but maintained a response without drug for any reasonable period of time? Call it, 4 to 6 months.
I have not.
No. All right, we're almost out of time. This is the tarlatamab. This is sort of for neuroendocrine. This is the DLL3 targeting agent. You see the small cell lung cancer Michael referred to. Obviously, small cell of the prostate is a terrible disease, right? And we treat it like small cell lung cancer, and they respond, and then they do poorly and pass away. That's been my experience, right? And so where is this fitting in the treatment?
This is not being really developed for the 3% of people who have de novo small cell. This is really being developed for those who have treatment emergent post-ARPI neuroendocrine differentiated or along the neuroendocrine spectrum, which is 15% of patients who are post-ARPI. So it's got a much broader potential for a relatively large number of patients who have no standard of care. So that's really where I think that the important target population is. And I do think that overall response rate at 10.5% is really a gross underestimation of the potential for the drug, because if you look at the patients in Rahul's study who are DLL positive, that's basically just under what you see for small cell lung cancer that led to approval of the drug. And the question is, in a very heterogeneous patient population, how do you identify the DLL3 positive patients? Because biopsies are really hit or miss. The distribution of disease by PET imaging is usually only the emergent and often visceral disease that's DLL3 positive, while the remainder of the disease is not. So it really depends on what you're biopsying, and patient identification is super important. And I think I'll now point to Karen, because she has a trial that's coming up that is specifically a follow-up from Rahul's study to look at that population and get some phase 2 data.
No, I think it's an extremely important patient population that, as Michael mentioned, has very few treatment options. And we know it has clear activity in small cell lung cancer, and there certainly is a portion of patients with treatment emergent or de novo neuroendocrine prostate cancer that express DLL3 and makes it a really...
And are you giving this now outside a trial?
Excuse me?
Are you giving it outside a trial?
I am not yet.
Anybody?
But we also have another clinical trial.
Fair enough.
I have a patient getting it right now, and back to Tony's question, there is all these logistics of getting the patient admitted to the hospital, authorization, all this logistical framework that goes with it. I think it's worth it. The question I have for you is, do you think that this drug, we're trying to see if we can give it outpatient, this specific drug with proper long-term monitoring? Do you think it's reasonable? Do you think it's risky? Any comments on the location of administration?
Well, as we said before, I mean, there are trials looking to determine the safety and the procedures needed in order to move this into the outpatient setting, but the label is what the label is right now, which is observation, doesn't specify admission into an inpatient floor.
Okay.
And I don't think most hospitals would admit those patients.
It's audience question time. Sorry for my voice. So question is, one or more T-cell engager therapies, pick your favorite, will be FDA approved in prostate cancer in the next 3 to 5 years? Yes or no?
The question that we see.
Oh, this is the wrong question. This is a preview to the kidney cancer question. There we go.
Yay.
Hopefully that people who answered are answering the right
Nice
question.
to see the optimism of the group.
Well, it's only one, actually.
Well, of that
But
one
it's
person.
sticking, it's
That's
sticking.
Petros.
True. It's true.
How did you see the end? Oh, there you go.
Karen, while people are voting, what's your answer?
Yes.
Yeah,
Within 5 years.
Yes, I do.
we'll go there.
absolutely.
Within 3 years?
Well,
Well,
even if you got the trial
Then you're asking me
started,
which drug.
I think if you, let's say it starts in 2025 and it
Just
accrues for a year and a
timelines.
half,
Yeah.
and then you have some...
And you think the drug that would be FDA approved already has data like what we've talked about, drugs that we've talked about today or were on that table? Or is it the next generation?
I think drugs we talked about today are in that timeline, and I think there are other drugs that are in that timeline that we haven't heard about yet.
And what, maybe last question for this session, we're running out of time, is if you were, in charge of everything and you could do that, what does that trial look like? I'll ask each of you that question. We'll maybe close on this. I think this is my last one. what does that trial, what does that registration trial look like? Drug X, let's forget about the drug. It's some T-cell engager.
Well, I think all of our data thus far is late-stage disease, which is where the registrational trials will go.
Versus a single-arm trial, it's randomized, was control arm.
Maybe physician's choice. I mean, ARPI would be a clear winner, but I don't know if that's a fair control these days anymore.
Yeah, I hope that chemotherapy would be allowed as a control.
So MCRPC, Drug X versus chemo.
Physician's choice, probably.
Okay.
I think true physician's choice control arms will have regulatory issues because it will be such a heterogeneous group. But I think that a controlled physician's choice control arm would be
Like
a
option A, B, or C
percent
or something.
of DOSI, a percent of ARPI, a percent of Pluvicto or whatever. I think you need to pre-plan what physician's choice will look like so the statisticians can determine a treatment effect for each segment of that.
Okay. We can go back to the slides. I think that's it. All right, thank you. Appreciate it.